Hello, everyone. My name is Luis Puig. I'm a board member of the International Psoriasis Council, and I'm very happy to welcome you to the second edition of the Global Webinar Series for 2023. On current knowledge and future directions in psoriasis, we will cover psoriasis in patients with cancer or chronic infections. And it is interesting for you to remember that this webinar will last 60 minutes. It is being recorded, and the recording will eventually be available at the web page of our organization. The audio is muted, and we should ask you to pose your questions through the question and question and answers window of the Zoom application. And there is translation available, so you can turn on closed captions for language options. The International Psoriasis Council is an organization founded in 2004 it's dermatologist-led, voluntary global, non-profit with a network of more than 130 experts in psoriasis dedicated to improving patient care around the globe. And our mission is to improve the care of those patients through research, education, and advocacy. And no matter where they live, how complex their symptoms, they should have access to the best care available. And that ultimately a world without psoriasis might be possible. So these are the distribution of our board members and councillors that represent 36 countries, and they volunteer their time to implement all International Psoriasis Council programs and activities with a very strong participation of up to 86%. So the key areas of our focus are one side, medical education, then access to care, research, and regional development. And regarding medical education, this is the goal of this seminar. We also have fellowship programs and several projects and partnerships providing a regional outreach. At our webpage, you can find resources such as library, assessments, and guidelines. And we have several activities regarding education with biosimilars, COVID-19, disease severity, and several quizzes. And you can meet the experts and also attend several events. And I would like to discuss or to remind you the International Psoriasis Council events for this year. On May 10, the Disease Memory and Disease Modification in Tokyo. On May 26, the IPC and Solapso Symposium in the course of the RATLA meeting. July the 3rd, the International Psoriasis Council Symposium on Psoriasis Management and Treatment at the World Congress of Dermatology in Singapore. And then we have also a global webinar, number 3, discussing the joints, a symposium at the European Academy of Dermatology and Venereology meeting, and the global webinar number 4, Psoriasis and the Gut, which we'll know soon the event date. We would also like to remind you of the Psoriasis Gene to Clinic that will take place in London in 2024. And the program for today is it will be presented by a wonderful program faculty. We have Professor Skov from Copenhagen, from Hellerup, Denmark. Then we have also Paolo Gisondi from the University of Verona, Italy. And Ricardo Romiti from the University of Sao Paulo, Brazil, another International Psoriasis Council board member. And first of all, I would like to introduce Professor Skov, who is a professor and senior physician in the Department of Dermatology and Allergy at the University of Copenhagen's prestigious Herlev and Gentofte Hospital. She was awarded her professorship in dermatology at the Faculty of Health Sciences from the University of Copenhagen in 2009 in recognition of her extensive contributions and training in dermatovenerology. Since 2013, she has been a coordinating professor for one of the largest hospitals in the Copenhagen area, and her current research includes projects comorbidities in psoriasis, primary diabetes and cardiovascular disease, and clinical intervention studies in psoriasis. Professor Skov, the screen is yours.
Thank you. Thank you for the nice introduction. And now I will share my screen. I think it's here. I have to put it on full screen. Yes. And I will talk about psoriasis and cancer epidemiological associations. And first of all, my disclosures. And then I have a little agenda, and I will talk about the risk of cancer in patients with psoriasis, potential risk factor for patients with psoriasis, and a little bit about the risk of cancer in patients with psoriasis on biologics. One of the first major studies looking at cancer in patients with psoriasis was a study from US, including data from 3 states in US and more than 250,000 persons. And the authors were looking at the risk of cancer in patients with psoriasis compared to patients with hypertension. And they were able, due to systemic treatment or not, to separate the patient with psoriasis into patients with severe psoriasis and patients with less severe psoriasis. And they found that there was an increased risk of cancer clearly in patients with severe psoriasis, but not in patients with mild psoriasis. And that was in a way a start, and there has been a lot of studies looking at the risk of cancer in patients with psoriasis afterwards. And in 2013, the first large meta-analysis were published in JADV, and there was another following up from UK in JAMA Dermatology in 2019, where they perform a systematic review and a meta-analysis on the risk of developing cancer in patients with psoriasis and also the risk of dying of cancer. And they were able to include 50 studies with the incidence of cancer, 15 on reporting on cancer mortality, and 7 studies reporting on both. And what they found was that for all psoriasis, mild or moderate or severe, there was a small increase in cancer overall. If they look at studies only including patients with severe psoriasis, there was a little bit larger relative risk of getting cancer in patients with psoriasis compared to healthy controls. They then also look at which type of cancer did they found, and it's important to notice that many of the studies on the single cancers, there's only few studies, 1 to up to 7 for keratinocyte-derived cancer. So it's based on relatively few studies. But what they found was it was mainly squamous cell carcinoma, basal cell carcinoma, and lymphoma. But they also saw a little increase in esophagus cancer and liver cancer, but mainly the non-melanoma skin cancer and lymphoma. They also looked at the risk of dying of cancer, and there was only few studies. They were able to identify 3 studies looking at cancer overall, and they didn't find any increased risk. If they then look at studies with severe cancer, they were able to find 4 studies, and they found a little increase of risk of dying of cancer in patients with psoriasis compared to the background population. This meta-analysis was followed up by another one we performed 2 years later, also published in JAMA Dermatology, and we look at the prevalence of cancer and the relative risk of having cancer in patients with psoriasis. And we were able to identify 112 studies. We included both patients with psoriasis, but also patients with psoriasis arthritis. And we looked at the incidence and the prevalence. And in total, there was more than 2 million patients included. And what we found was a little bit repetition of the first, that if we looked at cancer overall, there was an increase in patients with psoriasis. If we looked at cancer without non-melanoma skin cancer, there was still an increased risk. if we looked at, of course, non-melanoma skin cancer, keratinocyte-derived cancer, there was clearly an increased risk. And beside that, we did found a small increase in risk in melanoma, in lymphoma overall, in also the separate as non-Hodgkin's lymphoma and non-Hodgkin's lymphoma. We saw an increase in lung cancer and in bladder cancer. And if we only look at patients with psoriasis arthritis, there was no overall increased risk, but there was only for one of the single cancer, namely breast cancer, that there was an increased risk. And what could be the explanation for this increase of cancer we see in patients with psoriasis? There are several possible explanations. One of them is the treatment we use for psoriasis. We use a lot of UV treatment, and especially we have used early on a lot of PUVA, and it clearly increased the risk for melanoma and non-melanoma skin cancer. We use some systemic treatment, which also increased the risk, as cyclosporine. And for early on, we, at least here in the Scandinavian continent, have used tar for psoriasis, probably also increased the risk of non-melanoma skin cancer. Besides that, the chronic low-grade inflammation that you see in psoriasis may also have an effect on the cancer risk and may increase the risk, especially for lymphoma. And this fits with that we see this increased risk of lymphoma in patients with psoriasis. Also, patients with psoriasis have several of the well-known cancer risk factors increased in patients with psoriasis, as obesity, an increased smoking, drinking alcohol, and non-alcoholic fatty liver as a consequence of mainly obesity, but all that these risk factors are known risk factors for cancer and may increase the risk in patients with psoriasis. And the last thing is that patients, especially with severe psoriasis, are more often seen by doctors, and thereby it's more common that we will detect the cancer, and that's especially when they are seen by dermatologists. Is maybe the case for the non-melanoma skin cancer, but also due to our treatment, we take more blood samples, and by that identified the cancers. But what is then also the problem in the daily life? How do we treat this patient? And therefore, there has been a lot of focus on the treatment we use now, and especially for the severe cancer. And of course, people were worried about the biologics because they affect the immune system, and would they have an increased risk of cancer due to the treatment. And there has been some studies, not so many still, but there was a systematic review from UK, Pelava, looking at studies where patients have received biologics and the risk of cancer. And they were able to identified 8 studies, and they find an indication of a small increased risk of non-melanoma skin cancer. But they also said that there was few studies, and there was not so good studies, and with pure control groups. So we actually need more data. We also, in the study from 2020, look at the risk of cancer in patients on biologic treatment, and we didn't find any increased risk for the overall cancer risk without keratinocyte cancer, or keratinocyte cancers alone. but we still need more data, and I'll just take a few studies with us. This is a study from Denmark from 2020, where the group has identified nearly 26,000 patients with inflammatory diseases, inflammatory bowel diseases, rheumatoid arthritis, but also psoriasis, and then seen whether the patient had a history of cancer, and then look at how many were on TNF-alpha treatment after they have had a cancer, and then identified 434 patients and matched them to 10 times as many patients, and then have a follow-up for nearly 6 years and look at the risk of a new cancer and the risk of recurrence of cancer. And when they look at overall both new cancers and the risk of recurrence, they couldn't see any difference in the patient on biologics, the red one, compared to the one who were not on biologics. And if they look only at the new cancers, neither any difference, and not at the recurrence, indicating that the TNF-alpha treatment didn't affect their risk of cancers. Of course, people are also interested in the more new biologics, and the first one here is 5 years following up of patient which has been treated with secukinumab in the clinical trials, where the authors collect all the clinical trials and look then at the incidence of cancers compared to the expected incidence, and there was no increased risk of cancer in the patient treated with secukinumab. And just a new published article in JAMA, looked at the risk in patients with the first anti-IL-23 guselkumab, and look at the risk of cancer in the patient treated for 5 years, and they looked every year compared to the expected risk in US, and there was no increased risk of cancers seen. So just to sum up, there's an increased risk of cancer overall. It's slight in patients with psoriasis, and it's especially keratinocyte cancer and lymphoma, and there's no overall increased risk in patients with psoriasis arthritis. The increased risk is most likely a combination of the chronic low-grade inflammation, but also the risk factors for cancer seen in patients with psoriasis, and then the treatment we use for psoriasis, and especially the more formal treatment. And the most well-known cancer risk factor we see an increase in patients with psoriasis is smoking, obesity, and alcohol. And there was no increased risk in cancer in the studies published until now with patients on biologics. Thank you.
Thank you very much. Thank you very much. There's no question from the audience. So for the sake of time, we'll leave the discussion of your excellent presentation for the end. Thank you very much. Now it's my pleasure to introduce Professor Paolo Gisondi. He's an associate professor of dermatology and mineralogy and president of the residence program of the School of Specialization in Dermatology and Mineralogy at the University Hospital of Verona. His main scientific interests include the epidemiological, clinical, and therapeutic aspects of chronic plaque psoriasis and psoriatic arthritis. And apart from clinical research, he's a very busy clinician and with a large experience that he will share with us. Paolo, the screen is yours.
Thank you very much, Luis. Thank you very much, Peter, and all the members of IPC to having asked me to join this webinar. I'm very pleased for this, and thank you. I think that you can see my screen, right? So the topic is psoriasis treatment and cancer, new perspective. And I will introduce you the story of Roberto. Roberto is a 62 years old man with diffuse psoriasis and psoriatic spondylitis, as you can see in the picture on your right, that has been treated with infliximab for 3 years with good disease control, either on the skin and joint symptoms. However, Hodgkin lymphoma stage 3B was diagnosed while Roberto was on biological therapy. And so, what would you do in these circumstances? So Roberto is on infliximab, TNF inhibitors, and develop biological therapy. Interrupt the therapy, continue the therapy, or discuss with the hematology whether to interrupt or continue the therapy with TNF inhibitors according to the clinical condition of the patient. What happened? The therapy with infliximab was interrupted. I stopped the treatment. We can discuss after if you agree with me with these choices. Patient was referred to the hematologist. Hodgkin lymphoma was treated with chemotherapy and radiotherapy. And fortunately, psoriasis was cleared during this chemotherapy and radiotherapy period. So I asked to myself, is there is any risk of Hodgkin lymphoma in patients with psoriasis? Yes, no, maybe, has never been investigated. We performed a systematic review and meta-analysis investigating this outcome, with the objective. Why? Because it has been reported an increased risk of lymphohematological malignancies in patients with rheumatoid arthritis, IBD, for instance, and systemic lupus erythematosus, Sjögren's syndrome, and dermatomyositis. It is likely that in a genetic predisposed background, immune signaling dysregulation, inflammatory environment, as long discussed earlier, could lead to a chronic activation of B and T cells that contribute to the pathogenesis of lymphoproliferative disorder. So we did these systematic reviews. We selected more than 1,300 manuscripts. We screened, and a total of 25 observational studies were selected, including collectively more than 2,500,000 subjects. And we found that a significant increased risk for lymphohematological malignancy, any lymphoma, Hodgkin lymphoma, non-Hodgkin lymphoma, and multiple myeloma and leukemia was found in psoriatic patients compared to control. And among lymphohematological malignancy, cutaneous T-cell lymphoma has been more related, more associated with psoriasis. And again, this could be related to the exposure of systemic immunosuppressive therapy, comorbidities, and the effect of sustained immune activation, particularly on the skin. Then we asked to ourselves, is there any risk of cancer in patients with psoriasis on biological therapy? And also this topic has been already discussed by Lone, but very briefly, in this study, an increased risk of non-melanoma skin cancer, particularly squamous cell carcinoma, was reported with TNF inhibitors, but no risk regarding other type of cancer, including lymphoma, melanoma, prostate, colorectal, and breast cancer. And also this study has been mentioned. Fortunately, in these large studies, data on treatment with biological agent did not show an increased risk of cancer. And in this study from Verona, from the epidemiological department, seem to suggest no differences exist between treatment of chronic cutaneous disease with TNF inhibitors, ustekinumab, apremilast, tofacitinib, and conventional DMARDs in terms of melanoma, while data on non-melanoma skin cancer are more controversial. So in this study, it was a comparison between biologics and conventional systemic treatment. So coming back to Roberto. After a period of 3 years of remission, recurrence of diffuse psoriasis was observed, as you can see in the picture. PASI 22, BSA 70%, physician global assessment 5, and also back pain complaint. Then Roberto developed also diabetes, likely related to the corticosteroid therapy, arterial hypertension. So he was receiving also metformin and ACE inhibitor. So now, which treatment for psoriasis would you recommend now for Roberto? Topical therapy? I think that topical therapy is not enough in the case of Roberto. Acitretin could be good for the skin, but not for the spondylitis. I'm not expecting an efficacy of acitretin on spondylitis. Cyclosporin, I think you will agree with me that it's not the case to prescribe cyclosporin for Roberto, either for the comorbidities, either for the history of previous lymphoma. So no cyclosporin. Methotrexate, why not methotrexate? Although it's not so effective on the spondylitis compartment, but for the skin. Biologics, apremilast, fumaric acid esters, others. Phototherapy was not feasible at this time because Roberto was on the mountain close to Verona, so not easy to come to the hospital 3 times a week for phototherapy. What I did? Firstly, what guidelines are recommending? This is our for the Euroderm guidelines. Guidelines recommend, taking the burden of psoriasis into recommendation, and it should be a shared therapeutic decision, taking into account also what the cancer specialty suggests us. So for a patient with recent malignancy, recommend topical therapy, phototherapy, and or acitretin. In case of inadequate response to topical therapy, phototherapy, narrowband UVB, and or acitretin, guidelines suggest using methotrexate in patients with psoriasis and previous history of cancer. And they suggest apremilast can be used in psoriasis patient with a previous history of cancer despite the long-term experience based on pathophysiological consideration and case-by-case basis, including discussion with the cancer specialist against. Suggest against cyclosporin, as we discussed before, in patients with psoriasis with a previous history of cancer. And then suggest anti-TNF ustekinumab based on existing safety data on case-by-case basis, and also suggest IL-17 and IL-23 inhibitors can be used in patients with psoriasis and a previous history of cancer, despite the lack of long-term experience, but based on pathophysiological consideration and case-by-case basis, including discussion with the cancer specialist. We have a small experience. This is in 12 patients with IL-17 inhibitors. This is a case series with different type of malignancy, resolved malignancy, when methotrexate was not enough, was not effective, acitretin was not effective, and phototherapy was not feasible. So we have an experience with IL-17, different type of IL-17 inhibitors, and a follow-up ranging from 6 to 48 months with no recurrence of disease progression. Then even for Italy also, we have participated to these multi-center studies, observational study with different 42 patients with different type of cancer, from melanoma to breast cancer, kidney cancer, prostate cancer, and all treated with secukinumab, so again IL-17 inhibitors. Most cases were in early stages, only 4.8% at distant metastases. The secukinumab was effective with a mean PASI reduction 90%. No tumor recurrence, no progression occurred over a mean of 56 weeks. 3 patients developed a new malignancy, but not related to the previous cancer. So coming to the case of Roberto, firstly, I give to Roberto methotrexate, 15 milligram weekly plus folic acid administration, but the response was not good, was poor, not satisfactory response. So IL-17 inhibitor was combined, has been combined, achieving almost complete clear control with satisfying back pain control. I think that you are convinced that the response of the skin is very good. And fortunately, the psoriasis still is in remission with no recurrence of lymphoma. So in summary, in the setting of patient with malignancy and history of malignancy, selecting the appropriate treatment for psoriasis could be challenging, because patients with malignancy are excluded from clinical trials. In this setting, collaboration with cancer specialists is very important. Multidisciplinary approach is a value, and a limited number of treatment could be preferred in case of recent malignancy. But we should consider that there is a relatively small number of patients treated with biologics, with heterogeneity of cancer type and short duration of observation. So in conclusion, my feeling, my perspective is that any coin has 2 faces. In the picture on your right, you can see a sestertium, the ancient Roman coin. It was a present from my father. From another phase is the risk of relapse. The other phase is the need to treat the patient. So in the case of patient with history of malignancy, I think that is wise to know how to balance the risk of recurrence with the opportunity to offer to the fragile patient the treatment for severe psoriasis she needs. Firstly, I prefer phototherapy, methotrexate, and apremilast, but if a patient requires biologic, I prefer IL-17 or IL-23 inhibitors. Thank you very much for your attention.
Thank you very much, Paolo. There's no question on the screen. Perhaps I would like to ask you, do you take into account the potential mechanisms of the different cytokines we are blocking as regards cancer when choosing one biologic or another?
Beautiful question, Luis. I mean that, for instance, IL-17 has been implicated in the tumor progression of lung cancer, and it has been an hypothesis that could be used, IL-17 inhibitors, as adjuvant treatment for a targeted anti-cancer therapy. So, for instance, in patients with history of lung cancer, IL-17 inhibitors are preferred to me also for this reason.
Excellent. That's something that we will take into account. Thank you very much.
Thank you to you.
Now it's my pleasure also to introduce Professor Ricardo Romiti. He is responsible for the Department of Biology at the University of Sao Paulo, Brazil, and works as a clinical professor of dermatology at the University of Sao Paulo. Professor Romiti is currently a board member of the International Psoriasis Council, a member of GRAPPA and the Latin American Society of Psoriasis, SOLAPSO, and also the editor of the Brazilian Consensus of Psoriasis of the Brazilian Society of Dermatology. Ricardo, the screen is yours. Thank you.
Thank you, Puig. I'd like to thank the IPC too for the opportunity to be here with you today. And we're discussing psoriasis treatments and chronic infections. These are my conflicts of interest. So we know that different classes of drugs used in the treatment of psoriasis present a higher risk of some specific infections, such as, for example, here on the upper left, the occurrence of peritoneal tuberculosis in a patient under anti-TNF treatment, the occurrence of candidiasis and even of dermatophyte infections during anti-IL-17 drugs, and even the risk of herpes zoster during the NeuroJAK inhibitors. But when we talk about the risk of infections, when do specifically these side effects tend to occur? Is it mostly at the beginning of treatment? Is it mostly during some years of therapy? Here we present data from the Swedish biologics registry evaluating anti-TNF therapies, showing higher risk of infections during the first years of treatment. The most commonly reported infections were respiratory infections, gastrointestinal, and skin infections. Similar data we have from the British Society of Rheumatology registry, showing a higher risk of serious infections with anti-TNF drugs, namely etanercept, adalimumab, and infliximab, during the first year of treatment. And this occurs opposite to what we see with the DMARD treatments, where the risk of infections tends to be higher later on during the treatment. Concerning the use of interleukin blockers, we know that the risk of infections tends to be stable throughout the years. Here we see that the rates of infections, for example, with ustekinumab during the pivotal studies, tended to remain low and stable during all the 5 years of follow-up with this modality treatment. But is there really a higher risk of serious infections when we talk about treatments of patients with psoriasis? Here we see the results from a systematic review of the literature, evaluating randomized controlled trials and really showing no risk of serious infections with the use of anti-TNF blockers. This was published in 2011, and the risks were not higher for the psoriasis patients and also not for the patients with psoriatic arthritis. Here we see data from the British Association of Dermatologists, also showing no increased risks of serious infections for anti-TNF drugs. Here, specifically when compared with non-biologic therapies as methotrexate. Here, having a look at the SOLAR registry, we note that the risk of infections with the IL-12/23 blockers are lower, specifically when compared with anti-TNF drugs as infliximab, and comparable to the use of non-biologic treatments. More recent data showing systematic reviews of the literature and meta-analysis published last year, evaluating the IL-17 and IL-20 and 23 blockers, also presented no increase of serious infections with these newer treatment modalities. The authors also had a look at the candidiasis infection, and we know that there is a specific group of patients, those ones using IL-17 blockers, that have a higher trend to develop candidiasis due to all the mechanisms of IL-17 blocker, IL-17 interleukins in protecting the body against this kind of specific fungal infection. And what about specifically chronic infections as tuberculosis? Here we see very recent data from the World Health Organization stating that about 1/4 of the whole global population is estimated to be infected by Mycobacterium tuberculosis. Nowadays, worldwide, tuberculosis is considered the 13th leading cause of death and the second leading infectious killer only after COVID-19 infections, and even above HIV and AIDS. In 2021, there was an estimated 10.6 million people falling ill with tuberculosis, and a total of 1.6 million people dying from tuberculosis in 2021, including over 180,000 patients with HIV. We know that the general population, when presented latent tuberculosis, have a natural tendency of reactivation during their lifespan, and this seems to affect more specifically some groups of patients, those ones with compromised immune systems, of course, those patients living with HIV, those patients with malnutrition, diabetes, and even smokers. Here we see our beautiful city of Rio de Janeiro in Brazil. But we also know that although being such a nice city, Rio de Janeiro nowadays is considered the city with the highest incidence of tuberculosis in Brazil. We see here Rio de Janeiro at first point, just being followed by the Amazon area concerning the incidence of tuberculosis. We know that when we use anti-TNF blockers, we have a tendency for the TB granuloma to be broken down and allowing the dissemination of mycobacteria. So the risk of reactivation of tuberculosis is specifically high in this group of patients with anti-TNF blockers. And when we compare the 5 to 10% high risk of reactivation at the normal population, during anti-TNF blockers, this risk may be up to 9 times higher when compared to the normal population. Here, just to exemplify, this is one of our patients at the Hospital das Clínicas in São Paulo. This patient had a brother with tuberculosis, but he denied this information when being evaluated for the first time because he had heard that perhaps patients with a history of contact tuberculosis would not be permitted to receive biologic treatment. So he omitted this data. It was about 10 years ago. And so when he started his anti-TNF treatment, after a period of 3 to 4 months, he started to develop ascites. And here we see his picture with the diagnosis of peritoneal tuberculosis. Here, another case of ocular tuberculosis. We know that in many instances, cases of TB are extrapulmonar and extrapleural, and we have some very rare and specific manifestations also being reported as this specific case, and even more rare here, a case of tuberculosis affecting the tongue of a patient during anti-TNF therapy. But we know that since adequate screening and chemoprophylaxis started to be introduced here about the year 2001, here we see data of the infliximab risk of tuberculosis. We see how dramatically it tends to drop after this program was initiated in a worldwide fashion. And what about traditional systemic therapies of psoriasis? Is there also a risk of reactivation of tuberculosis? Here we have data from the Swedish registries looking at patients with rheumatoid arthritis specifically, showing that methotrexate was not associated with an increased risk of tuberculosis, specifically when compared to other drugs like leflunomide, azathioprine, and specifically prednisone, that presented a higher risk of reactivation. We have some specific publications looking at IL-17 blockers. Here we see the group of patients being treated with these drugs during the pivotal clinical studies. In both groups, quantiferon tested positive and negative patients, no cases of reactivation of tuberculosis. There's a specific group of patients that was treated with risankizumab, the IL-23 blocker, during the ENHANCE study, out of which 31 patients that were diagnosed with latent tuberculosis did not undergo the traditional prophylaxis of these diseases. And during a follow-up period of 55 weeks, no single case of this group of 31 patients reactivated tuberculosis. We have some expert opinions published in the literature. This one by the group of Mark Lebwo, an up-to-date review published in 2009, stating that in general, it's safe to use IL-17 blockers and apremilast in patients with latent tuberculosis, that anti-TNF drugs and ustekinumab can be used for patients with psoriasis, but only after the adequate tuberculosis screening and prophylaxis has been initiated. We need additional data for the new IL-23 inhibitors, but we know that what we know so far from case reports and literature reviews, this class of drugs also seems to be very safe. Methotrexate and cyclosporine can be used in patients with latent tuberculosis, and we know that acitretin, also a not very effective drug, is considered one of the safest drugs to be used in this setting. And what about another chronic infection, hepatitis? We know that the presence or absence of hepatitis in our psoriasis patients is among the factors to be considered when deciding which approach we'll do to our patients. Patients with a history of or currently active hepatitis C, we know are a safe group to be treated with anti-TNF blockers, anti-IL-17, and even IL-20 and 12 and 23 blockers. But we always state that the concomitant management with the appropriate health care provided is mandatory for these patients. Patients showing a positive serology of hepatitis B should always be seen by a specialist, and in cases where it's indicated, prophylactic antiviral treatment should be started. In those cases, lamivudine and entecavir should be started prior to initiating our biologic treatment. When we are to start this prophylaxis, it should be started at least a couple of weeks before the administration of the biologic drug and continued at least up to 6 months after biologic treatment has been discontinued. Here, another expert opinion publication recently out in the literature looking at hepatitis B and biologic systemic treatments, where the group of experts, including Alexander Ekberg and Ashwin Wu, states that in this group of specialists, one of the first class of drugs that should be an option for patients with hepatitis B should be IL-17 blockers, followed by IL-23 blockers, and then as a third class options, ustekinumab or anti-TNF inhibitors. We have some specific publications looking at specific classes of biologics. Here we have a study looking at a group of patients treated with secukinumab, and during all this follow-up study of patients under treatment with secukinumab, there was only one single case of reactivation of both hepatitis B and C. But this patient is specifically out a group of 60 patients had done no prophylaxis and no treatment before trying secukinumab treatment. And to finalize HIV, we know it's always an issue when we make an option for our patients with psoriasis treated and have this infection also. We know that patients with the HIV virus have a higher prevalence of psoriasis, have a similar prevalence of psoriasis when compared to the population, but when not treated for the HIV infections, these patients tend to be more serious and have more aggravated cases. The incidence and severity of psoriasis will correlate with the HIV load, and we know that it's essential to treat the HIV specifically before starting any specific treatment for psoriasis. We know that drug-related benefits and risks when treating a patient with systemic psoriasis are similar for non-HIV patients and patients with a suppressed viral load and normalized CD4 count. Before initiating psoriasis treatment, we should always address HIV replication together with the HIV specialist. And treatment decisions should, of course, be made case by case. And here to finalize, the same review by Mark Level stating which biologic treatments would be safe for patients with psoriasis, and stating that TNF blockers, ustekinumab and apremilast might be the first option. And once again, apremilast, acitretin considered a very safe option for this group of patients. I thank your attention.
Thank you very much, Ricardo. This is always so exciting. We have one question from the audience about if you are aware of Epstein-Barr virus reactivation with any of the biological agents or small molecules.
Epstein-Barr?
Epstein-Barr virus, yes.
Yeah, no, not aware of specific situations in this setting.
And can you comment on human papillomaviruses infections? Do you have any special, let's say, concern? What about vaccination? What's your approach to these patients?
Yeah, we know that it's mandatory, first of all, to screen these patients, or specifically female patients with their gynecologists, to check on HPV infections. We know there are reports in the literature of very severe and disseminated pictures of these viral infections in patients, specifically with TNF therapy. So we always have to check these patients appropriately. Whenever possible, really vaccinate young patients with the HPV vaccine, not just to avoid genital infection, but we know of the risk of oral and even laryngeal infections with this specific virus.
I guess this depends. Sorry, Paulo.
No. Also for cyclosporin. I mean that healthy patient, young patient, cyclosporin could be a good drug, but for female patient, you never know the status of infection with HPV. So it's better to have a screening before giving cyclosporin in this patient, because otherwise you have a risk of viral progression.
But I guess this might depend on the epidemiology at each different country. So it might not be the same in Colombia, Brazil, or Africa than in some other countries. But usually also depends on the healthcare systems. Usually our females are screened every year, more or less, or somehow have access to. But that's why in some countries screening for let's say SIN, or so human papillomavirus infection is not required, so it might depend on different countries. And regarding that, I wonder, do you have any evidence that in some patients from some areas, should we look for Chagas disease, strongyloides, Pleuronorchis? What's your take on that?
Yeah, and even leprosy and episodic disease always discuss some specific granulomatous infections. Chagas disease is very prevalent in our population, and we know that even when the patient has a positive serology, it's not mandatory that he has active infection, but traditionally, yes, we check for Chagas disease. HTLV infection, human TLV infection, it's very prevalent in the north of Brazil. And of course, parasitosis as strongyloidiasis. As we do before starting systemic steroids, we always screen for that and do the appropriate therapy.
Amazing. Thank you. And now it's hello, Peter. It's time to start the general discussion. We have another question. From Tobias Noor? What minimum investigation for tuberculosis should be done before starting any systemic non-biologic or biologic drug for psoriasis? Minimum investigation. I guess it depends on the availability of the test, but can you comment on that?
Sure. So concerning non-biologic treatment, we know it's very controversial whether we should check or not for latent tuberculosis. As I presented, we know that for methotrexate, for example, there is not an increased risk of reactivation of tuberculosis. Many state that we should screen the patient, already thinking that in the future we might start a biologic therapy. And a problem we face when we screen the patient before starting methotrexate, and he has, for example, a positive quantiferon or a PPD of 6, we are obliged to do chemoprophylaxis for this patient. So we have two problems. We have a patient that might delay his biologic treatment, and we'll be using probably two hepatotoxic drugs, chemoprophylaxis for tuberculosis and methotrexate. So what we do at our department, when we look specifically at traditional drugs, specifically methotrexate, we don't screen the patients before starting. Tuberculosis is so prevalent, and then it's the same way we do with systemic steroids. We don't screen our patients before starting a lichen planus. We know we might be taking the drug for a long time, so we really just screen specifically before starting biologics therapies.
You know, we are not using a lot of PPD in Spain, but I wonder if one patient for any reason shows positive to quantiferon and is younger than 40, shouldn't we start chemoprophylaxis to prevent reactivation or activation of latent tuberculosis, regardless of the treatment that we are going to give to this patient?
Yeah, this is really under debate. And some people say it should be done previously. Other groups said it doesn't. And as I say, in the past, whenever we try to be proactive and checking for latent tuberculosis, in Brazil, what's mostly available is PPD because it's free by the public health system. We've really faced this issue that we had to do the two combined drugs with all the care that is involved. So really, traditionally, we don't screen in advance to methotrexate.
Hi, Luis. For the screening to methotrexate, I usually do not recommend the screening of tuberculosis quantiferon, because if you find the positive, you need to do prophylaxis. And isoniazid plus methotrexate is a dangerous cocktail for the liver. So for me,
depends on the age. Yes, it depends on the age. So it's I see. Yeah.
Usually it's a dangerous because isoniazid could be toxic for the liver independently
Yes.
from methotrexate. Sometimes it absents and liver enzyme.
And fatty liver, of course. And just one question about the need to wait for 1, 2, 3, 4, 5 months of chemoprophylaxis before starting any kind of biologic treatment. That's expert guidance, but do you have any let's say second thought about that? Do you really believe it is necessary to wait, or should you use another drug when you don't want to wait?
Actually, I learned this from you, Professor Pucci, that there's no rationale to wait 4 weeks or more before starting the biologic treatment. This is just something that's been stated and repeated. So nowadays, really, when the patient is severe and we need urgently to start, we start both straight away. We don't wait a longer period of time. Of course, if we could wait, it's always good, but really there is no really much basis on this thing to be done.
Yeah, I agree with Ricardo. And today, fortunately, in Italy, the prevalence of quantiferon positive tests is lower compared to some years ago. And if I find a positive quantiferon test, for me, it's a good motivation to select IL-23 inhibitors and avoid chemoprophylaxis.
Mm-hmm. Excellent. One final question for Professor Skov. Do you really believe that once we take into account all the risk factors, is there any evidence that the inflammation in psoriasis might somehow contribute to increased risk of cancer that has been reported in so many studies? You're muted.
Sorry, maybe for lymphoma.
Maybe for lymphoma.
For lymphoma, but for most of all, I think it's not so important.
And in the case of lymphoma, you have imagine you have a patient with chronic lymphocytic leukemia with good prognosis. What would be your preferred biologic treatment for that patient?
I will do as Paolo. Also, I will contact the hematologist and discuss it with him. But I think I will just start an TNF-alpha blocker, because that is the first we have to use in Denmark, and I think it's okay. But I will make a discussion with the hematologist.
Okay, I have some bias against anti-TNF-alpha agents. That's why in many patients, even though we usually start with biosimilar adalimumab, I prefer to use IL-23 or something. But it depends on the country, I guess. So
and we are forced to use it, and I really see really seldom problems.
100%. You're forced 100%. Okay.
Yes. Also, we are very recommended to use a biosimilar, but in this particular setting, I think that could be a rational motivation to skip this passage and go to IR for safety reason.
Yeah, we're being given some slack in Southern Europe, so that's okay. That's good. And now I see there's Peter van de Kerk over there. Do you want to close the session, because we are a bit on the brink of the final of the session? It will be great if you want to close it.
Closing, that is, well, I enjoyed the lectures very much. It shows us also that we have got to go for a personalized approach in a way, and that also contacting our colleagues in other departments is important. When we have a patient with cancer, for example, and when you would have a patient with kidney cancer, you even can have an anti-tumor effect with an anti-TNF-alpha. There are so many complex issues when we go in more detail on the various comorbidities. And the other thing is also looking for evidence. What would it be great when we would have more data? We have already a lot of data by our own experience, by even more data on registry data on anti-IL-17s and anti-IL-23s in relation to activation of tuberculosis. I have the feeling that we are doing a lot of testing in vain, that it's not needed, or give selective treatment where it's not needed. But we have to adhere to what the guidelines are telling us and suggesting us. So we need additional studies, I think, here. So I think it was a very inspiring symposium. Thank you so much. And it was great at the distance to hear this great meeting. Thank you so much.
Thank you very much. Thank you all the attendees, all the presenters. We will have the third symposium on June the 20th. And I would like you to, all the attendees, please to complete the attendee survey that is shown in the chat. Thank you very much and have a wonderful day and time.
Ciao.
Bye-bye.
Ciao.
Bye, Ricardo. Bye.